Right.
We'll start, sir. A very good evening to one and all. I heartily welcome all the members of API, ICP Karnataka and other members of various organizations who have joined virtually from all over the country to attend this program on update on artificial intelligence in medicine. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus RGHS and KVN University Gulbarga. I also welcome our own committee members, the patron Dr. Maya, API, Dr. Suresh Sagrath, Chairman API Karnataka, Dr. Vishwanath Secretary, Dr. Ravi Kirti and Dr. Srinivas Murthy. I welcome our today's chief guest, Professor Dr. R.K. Singhal, Dean ICP, National API from Delhi, who was kind enough to accept the invitation and join a great academician, researcher who has taken National API to an international level by doing great academic events of ICP, a great name in API family in the country. I also welcome our today's speaker, Dr. G.V. Rao, a dynamic personality in GI surgery, who is the director and head of GI surgery, B.C. Roy awardee, who hails from AAG Hospital, Hyderabad, a great surgeon, academician of international repute, received many awards, fellowships with many publications, both national and international, one of the pioneers in laparoscopic surgery in the country, with special interest in innovation and artificial intelligence applications in medicine, is working with Dr. D. Nageshwar Reddy, a world-renowned endoscopist, heading the prestigious premier academic institute of our country, AAG Hospitals, Hyderabad. I also welcome our chief moderator, Dr. Murali Mohan, the past chairman API Karnataka and the pulmonologist from Narayan Hospital, Bangalore. I also welcome our today's panelist, a close associate of mine, Dr. S.V. Kulkarni, a physician from Navi Mumbai, who has special interest in tech-derived medicines like telemedicines, machine learning, and artificial intelligence, who has many publications to his credit. I also welcome our other panelist, Dr. Sabita K. from Kerala, who has special interest in artificial intelligence in medicine application and done a lot of work on it with many credentials and research publications. Let us not waste time by reading their CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually from many states of the country, making a national event, which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते शुभम्.
Yeah, now we are virtually honoring all the faculties as well. Now I request Dr. P.S. Shankar to address and for his introductory remarks.
Dr. Singhal, Dr. G.V. Rao, dear colleagues and friends, we have assembled here today under a new leadership of the state body of the APA, headed by Dr. Sagrath, for an update on artificial intelligence in medicine. And I welcome you all. Artificial intelligence, AI, sometimes called machine learning, machine intelligence, is a branch of the computer science exhibiting intelligence demonstrated by the machines in contrast to the natural intelligence displayed by the humans and other animals. AI is the stimulation of the human intelligence by the machine. AI has made the computers to think intelligently in a similar manner as the intelligent humans think. AI is accomplished by making us study how human brain thinks and how humans undertake learning, make decisions, and undertake work while solving a problem. AI encompasses different disciplines such as computer science, biology, psychology, mathematics, engineering, and linguistics. AI carries out computer functions associated with human intelligence. Artificial intelligence in medicine is the use of medicine machine learning models to help the process of the medical data and give medical professionals important insights, improving the health outcomes and the patient experiences. In our daily life, we encounter a huge amount of knowledge which is not well organized and it is not stationary. AI helps in organizing the information. It makes it possible to alter by correcting the errors. The knowledge can be used efficiently and speedily. A computer will analyze a large set of data and come to a conclusion through an algorithm. AI has made its entry into the healthcare industry. AI has been utilized in determining the accurate dose of the immunosuppressant agents and the anti-cancer drugs. A large number of medicines are available to treat cancer, and the treating physician finds it difficult to make selection of the right drugs for the patient. A machine has been developed that is able to memorize the literature pertaining to the cancer and help in predicting the combination of the drugs that will be most effective for each patient. Machines such as Hanover and Watson have shown that they can beat human intelligence in many situations. In the coming years, AI will support doctors in providing care to the patients. It can help in solving many smaller and real world problems, such as reducing the prescription errors or ensuring patients take their medications as prescribed. AI is primarily utilized to increase the speed and accuracy in the healthcare realm. Some of the current uses of the AI in this field include diagnosing the patients, AI algorithms to analyze medical imaging data such as X rays, MRIs, and CT scans to assist the healthcare professionals in accurate and swift diagnosis. Thus, AI has become a useful tool to support the work of the doctors to provide best quality care to the patients. Royal College of Physicians, London, has brought out a position statement on AI in health. It has urged to apply the AI in real world challenges such as prescription errors, medication adherence, and use of and resistance to the antibiotics. Utility of the AI has to be properly tested and evaluated. Doctors have the responsibility to appraise the efficacy and the utility of the new technology. Since real time data is so diverse, it has to reflect properly in the extended population. Artificial intelligent computer systems are used extremely and extensively in medical sciences. Common applications include diagnosing patients, end-to-end drug discovery and development, improving the communication between the physician and the patient, transcribing the medical documents such as prescription and remotely treating patients. While computer systems often execute the task more efficiently than the humans, more recently, state of art computer algorithms have achieved the accuracies which are at par with the human experts in the field of the medical science. While the human brain might process 4 or 5 of the likeliest paths through the figurative haystack, the most advanced AI models, known as language learning models, or the chatbots, can account for millions. Using the billions of data points, humans train chatbots to simulate each pathway through the haystack. The model in turn can receive new information, compare it to its trained memory, and select the most probable diagnosis. Chatbots are far from perfect. Whether the model pulls a needle or the straw out of the haystack depends on the data used in it. There is an old saying that garbage in equals garbage out. If you put the wrong information, you are going to get the wrong answers. We anticipate that the new technology will help the doctor to take a person centered approach to make best possible decisions in healthcare. Often, a question is raised whether the AI will replace the doctors. Though it is unlikely to happen in near future, we have to give careful consideration about its safety and ethical considerations. We are eager to hear the talk by Dr. G.V. Rao, followed by the panel discussion. I'm happy to associate myself in the part, the update, and thank you.
Thank you, sir. Thank you for your kind words of wisdom. Now I request Dr. Suresh Agarwal, Chairman API Karnataka, to address for the gathering.
Thank you, Sangram sir. It's a wonderful beginning of our tenure. And the first webinar is on the technology, that is the artificial intelligence, and that's the great beginning to our academic year. As Dr. Shankar sir has already introduced the topic and he has highlighted various issues surrounding AI. I think we need to listen regarding this topic because AI has influenced equally our personal life as well as professional life. And there are various issues surrounding the AI in medicine, whether it's going to, substitute or supplement or what it's going to be the future of medicine. There are many ethical issues surrounding it. And we need to have a continuous SWOT analysis of this AI. What are its strengths, weaknesses, opportunities, and what are the threats? So let's hear from our speaker, Dr. G.V. Rao. Thank you very much, sir, for being accepting this invitation and going to give us enlightening on this topic, and also the panelists on on this webinar. Thank you very much, Sangram sir. Let's go ahead with the program. Thank you.
Yeah, thank you, Dr. Suresh. Since our chief guest, Dr. R.K. Singhal, is held up in traffic, he is on the way to Delhi airport. He will be joining anytime. So before that, I request Dr. Murali Mohan sir to take over for further proceedings for the scientific session. For our scientific session, Dr. Murali Mohan sir.
Good evening, sir. Thank you for inviting me to moderate this very fascinating session. We can't attend any conference without having at least one session on artificial intelligence. And I think that speaks to the importance of it in current day-to-day life. As both Dr. Suresh Agarwal and Professor P.S. Shankar have said, it has made its presence felt in every single aspect of our life. We have a great panel and a great speaker today. I've heard Dr. G.V. Rao talking about gastroenterology in conferences. This will be the first time I have the opportunity to hear him talk about artificial intelligence. And of course, we have Dr. Savita and Dr. Kulkarni. So a great panel. Without standing between you and the speaker, let me invite Dr. G.V. Rao, the main speaker. He's going to be speaking on artificial intelligence in medicine, the very broad approach to the area.
Good evening. Am I visible?
You're audible,
Yes,
sir.
thank you.
Please
Yes,
go
sir.
ahead.
Audible,
Good
both.
Good evening. At the outset, let me thank the entire executive of the API and the ICP Karnataka for the honor bestowed on the surgeon. Thank you so much. It's very rare for a surgeon to get into the physician's armamentarium. Thank you so much. And I send my sincere thanks to the entire organizing committee, Dr. Singhal, Dr. Shankar, Dr. Sangram in particular, who is who has been the brain behind this entire show. Thank you, Sangram, for the honor bestowed on me.
Thank you, sir.
After listening to Dr. Shankar, I thought, I don't know whether I should continue my talk or I should stop my presentation. Beautiful exposition, Dr. Shankar. Within 2 minutes, you have covered the entire aspect of artificial intelligence,
Thank you.
right from the concept to the usage to the limitations of it. I'm amazed, actually, only senior people like you can sum it up in 2 minutes. Every time somebody asks you to do a presentation in 10 minutes, people keep saying that I cannot do my presentation in 10 minutes. But I think kudos to you, sir, that
Thank
you have
you.
summed up the entire thing within 2 minutes. So I'll try to see how best I can follow you, sir, actually. Thank you so much. I've personally seen you and we have highest regard for you people because basically I'm a protege of Karnataka. I did my surgery from Karnataka. So I have a long association with the Karnataka Surgeons and the Association. Thank you so much, sir, actually. So without much ado, thank you, sir. I'll just share my screen. Is that visible
Not yet.
now? Not
No.
visible?
No. Only you are visible.
1 second. One second.
Ah, yes. Now the screen appearing.
Is it okay, sir?
Yeah, yes,
It's visible.
yes.
Thank you so much, sir, once again. So I'll be talking about the impact of not only artificial intelligence, but there seems to be a lot of science fiction that is taking up artificial intelligence in current day clinical practice. And I'll show you how it is impacting the current day clinical practice. And being a surgeon interested in GI surgery and also interested in, to an extent in endoscopy, I thought I'll change this topic to the impact of science fiction and artificial intelligence on gastrosciences. I'm not Albert Einstein and I'm not Dr. Shankar to be as intelligent, please. Actually, I accept that Dr. Shankar, I bow before you to show you the amount of
None.
respect that I have. Actually, I am not Albert Einstein, neither I am Dr. Shankar to talk about artificial intelligence, neither I am Don McCarthy to be talking about artificial intelligence. Basically, I'm a surgeon with limited intelligence practicing in Asian Institute of Gastroenterology at Hyderabad, a premier institute predominantly concentrating on gastroenterology. So why am I talking about artificial intelligence? Basically, because I feel AI is part of AIG hospitals. So it has been part and parcel of AIG hospitals, and AIG hospitals under the stewardship of Dr. Reddy has taken this forward, and we have a separate department of artificial intelligence in AIG hospitals, which is trying to take this way ahead into clinical practice to see how it can benefit the patient population in general. So if we look at what patient care is about as in today, it involves clinical examination, investigations, interpretation, treatment planning, execution, and follow-up. All the senior physicians here are very well aware of all this, and they've been depending on natural intelligence and also our generation to come to a diagnosis and treat these patients. And also, in addition, we depend on research, training, and certain amount of the latest concept of burnout that is happening to the clinicians to see how this can be overcome in clinical practice. So all this we have been dependent on natural intelligence to see how it can be overcome. But now artificial intelligence seems to have come into each and every of these program to make sure how this can be taken forward. If you talk about on-site medicine, medicine as in today, it's basically about on-site medicine with some amount of empathy and natural intelligence in all these fields so that it can be taken forward. Artificial intelligence is the ability of a computer to perform tasks and cognitive functions like human beings. It is basically depending on the processing power and the processing speed of the computer, and the advances in the processing speed and power of the computer have created artificial intelligence, which is making dramatic entry into clinical practice. And this seems to have its applications which are far and wide, as Dr. Shankar has said, in diagnosis imaging, in physician support system, research and development, and to a biggest extent in the patient care in current day clinical practice. Basically, there are three types of artificial intelligence that we talk about. It's called artificial narrow intelligence, artificial central intelligence, or artificial super intelligence, which is taken forward by processes of machine learning, machine intelligence, and machine consciousness. The basic example of this can be just talk about an ECG that we currently read in clinical practice. And we all know that actually we, at the end of the time the ECG comes out of the printing machine, you have a basic diagnosis of it's a normal ECG or an abnormal ECG. To a certain extent, with the advances in this, it is able to give a diagnosis of the cardiac rhythm that we encounter in current day clinical practice. This has entered into clinical practice basically from the radiology specialty, wherein umpteen number of X-rays have been fed into the computer to give a diagnosis of this chest X-ray that we routinely see day in and day out. And this has led to dramatic progress. And this entry, which has started into medicine almost a decade back, and now seems to be replacing it. And now majority of the centers, including our center, is using artificial intelligence to report some of these plain X-rays that we see day in and day out in clinical practice. This does it by detecting, characterizing, and monitoring this entire process so that it gives a prediction which is almost similar to what the clinicians or the radiologists give. Surprisingly, as we are talking about artificial intelligence, there is another aspect called as science fiction. Science fiction is what we dream and what we try to translate into clinical practice. And many of the today's clinical practice seems to be what is seen in the science fiction stories or the science fiction movies that we see. And all these science fiction stories or the science fiction movies have majorly incorporated artificial intelligence into them to show how the medicine can be practiced in future. And there are several domains in the field of artificial intelligence, like we have in medicine, surgery, and gastroenterology. These are the domains in the field of artificial intelligence or science fiction who have predicted how future of medicine or surgery could be. And as I told you, artificial intelligence seems to be a recurrent theme in all the science fiction movies and also in the science fiction books that we have read, emphasizing the potential benefits and also the dangers of artificial intelligence into clinical practice or in general. The best examples of what we have seen of artificial intelligence and science fiction stories are these movies called Virus, Contagious, Pandemic, Contagion. All these movies came in almost a decade back, even before the COVID pandemic struck us. Surprisingly, anybody who has seen these movies would be surprised to see how these people are able to predict how this disease can start, how this disease can spread, how it can be treated, including the post-mortem examinations conducted. And if you've seen these movies very closely, significant amount of these movies have used artificial intelligence as their team to take this forward and how it is shown in clinical practice. So science fiction and artificial intelligence in gastrosciences seem to be the most happening thing in as and today, most curious because it's the most expanding specialty. It is the most invested specialty, most rapidly expanding emerging specialty in gastrosciences as and today. If you've seen all this, actually current day, majority of you would have seen images like this in current day clinical practice, which involves narrowband imaging, proboendoscopy, confocal endomicroscopy, laser-induced fluorescein spectroscopy, autofluorescent endoscopy. These are all current day clinical practices which are used to pick up lesions which are not picked up on conventional endoscopic imaging. Now what has gone, and also we have this modalities called as narrowband imaging. I think some of you physicians would have seen narrowband endoscopic images, which shows how lesions can be picked up in conventional blue light instead of the white light. And also this was used in laparoscopic side on the surgical side to pick up lesions which are not picked up on conventional white light. Now this technology has picked up tremendously on the endoscopy side, not so much on the laparoscopy side, but this has made several inroads and we are able to pick up lots of lesions which are not picked up on conventional imaging. Surprisingly, this concept of narrowband imaging seems to have been taken from the science fiction movie called as Predator, wherein for the first ever time, they showed the use of narrowband imaging or blue light to pick up camouflage structures which are not picked up on conventional white light. This is a beautiful concept which is shown in this movie called Predator. Now, endoscopy has further advanced. So we started incorporating a microscope at the tip of the endoscope, and now we are able to get on-site histopathology. You can see this. So initially we used to pick up biopsies and then send it for histopathology. So now we can touch the scope with the lesion and we make an on-table diagnosis of these pathology that we see in clinical practice. This is a big breakthrough in endoscopic practice, and now we are able to make an on-table histopathology as compared to conventional endoscopy. Now, endoscopy has taken a step forward now. Now, this has incorporated artificial intelligence into this, and now the moment you touch this lesion, this endoscope or the endobrain, and it is called, it will tell us whether it's a neoplastic lesion or a non-neoplastic lesion. Phenomenal advance in the field of endoscopy. And now, as of today, it is not that we are replacing a pathologist, but as of today, it is being used to avoid unnecessary biopsies so that the patient doesn't have to wait long time for waiting for the histopathology report. Phenomenal progress. We see that this is going to come into clinical practice. And in the days to come, it is going to also incorporate immunohistochemistry studies and give us a final diagnosis the moment you touch the lesion with the help of an endoscope. Now, after this Predator 1 that we have seen, we have another movie called as Predator 2, which has come, which had showed the use of infrared light for the first ever time. Here it uses infrared light to pick up lesions, to pick up camouflage structures. Beautiful concept which has used some amount of artificial intelligence when it started, but this has been translated into clinical practice on the laparoscopic side predominantly. But I'm sure in the days to come, we'll see more and more of this on the endoscopy side also. And we're using ICG, injecting ICG, and under infrared light, we're able to see these lesions. We are able to pick up nodes which are not picked up on conventional white light. We are able to check the perfusion of the anastomosis after we do major resections. And also it is able to pick up some of the lesions which are not picked up on conventional white light. So these advances in laparoscopy have made surgery safer, and ICG and infrared laparoscopy is a part and parcel of current day clinical practice in major centers across the globe as of today. The other modality that has come into laparoscopy is this technology called as yellow enhancement, which is involving artificial intelligence, wherein the yellow component of the tissues is enhanced to better depict, to better do dissections, which can decrease the morbidity and mortality associated with surgical procedures. Just to show you, the upper left-hand corner is showing white light laparoscopy, and the lower corner is showing yellow enhancement laparoscopy. You can see the sheer difference between white light and yellow enhancement, and this makes surgery very, very safe. In the sense, the amount of blood loss that is seen during surgical procedures is dramatically reduced, basically because you are able to see structures very clearly, lymphatics very clearly, and we are able to pick up nodes more than what is picked up on conventional white light. Now, this yellow enhancement is a new entrant into clinical practice, and a lot of centers have started incorporating this. And then we see in the days to come, we'll hear more and more of this technology that is making a real change into clinical practice in future. This is an anterior resection being performed under yellow enhancement, just to show you how safe it is, how less bloody it is compared to the white light laparoscopy that we see. Now, this concept has been devised from this movie called as Avatar, wherein for the first ever time they showed this concept of yellow enhancement. You must have seen this movie wherein these creatures have this yellow eyes, which is enhanced by artificial intelligence. Phenomenal concept, and Olympus company, which has started this yellow enhancements, has picked up from this movie called Avatar. And I'm also happy to tell you that actually AIG is involved in a new project called as Octopus. Now, I told you about the white light, the blue light, and the yellow light. Now, here we have to keep changing the mode on the processor to see which light we have to use during the dissection. But for the first ever time in the world, AIG is getting into this technology wherein the light spontaneously changes automatically depending on what you're dissecting, so that you don't have to keep changing the mode. Like the Octopus, it keeps changing the colors so that the surgical field is absolutely beautifully exposed, clearly gives a contrast of various tubular structures and vascular structures so that the surgery becomes very, very safe in future. I think next time I talk to the Karnataka chapter, I think I'll be able to show you how this Octopus project can be helpful in clinical practice. Now, we also have this artificial intelligence which has come into surgery, wherein we have in our theater right now these intraoperative sensors or cameras that are installed and that are linked to all the preoperative and the intraoperative data. This is something like, this is what is called as navigation surgery. Now, literally, we are walking through the images. All the preoperative images, be it with CT, MRI, and intraoperative ultrasound, are integrated, and we are running through these images as we are going through the surgery. It is like something like having a Google map, which is installed into your theater so that you can run across the thing. This is the example of this navigation surgery being done here. You can see the liver resection being done at our center, and you can see the real-time image, the 3D image, which is superimposed on that. Now, this is like having a Google map. It will tell us from point A to point B how much time it will take and whether the route that you're taking is the safest route, whether there are obstacles, where you have to slow down, where you can go faster. And by this, it is shown that it improves the decision making, decreases the operative time, decreases the complications, increases the number of R0 resections, and it facilitates orientation and localization of tumors which are not seen on conventional white light. Some of the tumors can be hidden in this, so these tumors can be visible seeing on this. So you can see this, we can rotate the image 360 degrees, and it is absolutely like having a Google map on top of the liver so that we can go in the least vascular area, and then the amount of blood loss is less. This is a technology that is making a tremendous impact and surgery safer into clinical practice. And the same practice is also involved in robotic surgery, and as I'll show you subsequently. Now we have another concept called as in vivo histopathology. Now I've shown you an endocytoscope which shows images which is benign or malignant. Now we have a new technology which incorporates AI, which can make a histopathology diagnosis on spot. We don't have to wait for the frozen section biopsy. And you can see this. This gives an image absolutely like a histopathology H&E stain. This takes about 5 minutes to give this, so we don't have to wait for the frozen section biopsy. You can see the dramatic change that has made into clinical practice. Now we have this in clinical practice. This is called as the Vivoscope that has come into clinical practice. And this gives us absolutely, as in today, we have to depend on the pathologist to read this, but in future, this is making progress so that this gives a diagnosis spontaneously on its own without having to depend on the pathologist. Now, robotic surgery is the other specialty that we keep talking about. Though basically robotic surgery, it's a myth that robot performs surgery. It only aids surgeons as in today. As in today, whatever laparoscopy is doing, we are able to do through robotics. The biggest advantage is the amount of the movement that the surgeon has got at the wrist is almost like the natural wrist, which is making surgery more safer. And some of the areas it has shown that it is superior to conventional open or laparoscopic surgery. But if you see this, how is this is natural intelligence. How is artificial intelligence getting into it? So every time you see an endoscopist or a laparoscopic surgeon, there are 4 types of movement that anybody does it. Somebody shows the laparoscopic camera, the surgeon or the endoscopist recognizes the pathology, he decides what to do, and he moves forward to do the surgical procedure or the endoscopic procedure. Now, AI is getting into each and every of these phases of endoscopy or surgery, in the sense how to show, how to recognize, how to decide, and how to move. So the end result is right now, for the first ever time, this entire surgery has been programmed in the sense, now you do the surgery on a computer, and once you're absolutely satisfied that the procedure is safe, you let the computer do the procedure. Phenomenal advancement in the field of surgery so that it can avoid the errors what we do in conventional endoscopy or surgery as in today. For the first ever time, an experimental work has been done to show how the entire surgical procedure can be programmed and let the computer or the artificial intelligence do the surgical procedure. This is still in infancy, but I'm sure in our lifetime, we'll be able to see these advances coming into clinical practice. And we also see this majority of the time that actually you must have seen science fiction movies like this, which show the concept of surgery in space that are integrated or done by incorporating artificial intelligence and performed by surgeons or endoscopists from the Earth. NASA has started this program right now, and then it is shown that this is feasible now, and they have done it in a model, in an artificial simulated environment in NASA, wherein they started performing surgeries in space, taking a cue from this movie called as Invictus sometime, which was released almost a decade back. Phenomenal advances that have led, and I'm sure in our lifetime we'll be able to see all these things that I've seen in science fiction movies, incorporating artificial intelligence to a significant extent. Now, if you see majority of the clinicians actually who are engaged in in today's webinar, you have seen that ICU is equipped with point of care, and we have objective alerts for every single thing, for vasopressors, IV fluids, antibiotics, blood products, oxygen, you name it, actually you have an alert. In the sense, you're sitting at the counter or at the console and you get an alert. Surprisingly, we don't have an objective alert for the nutrition. And majority of the morbidity that is happening in the ICU, be it with the medical ICU or the surgical ICU, seems to be because of inadequate nutrition that we provide to the patients in the intensive care. So this nutrition as in today is suboptimal, and it is shown that in various parts of the world, the ICU health or the nutrition, both in Africa's and America's, the same. Basically because you're dependent on natural intelligence, and that is suboptimal as in today. But for the first ever time, we know that nutritional therapy in ICU is a dynamic process, and we have to see whether we have to subjectively do this or objectively do this. And we have a new technology called as indirect calorimetry as in today. It's a very simple equipment, that artificially intelligent machine that has got a hood that calculates the amount of calories the patient requires in the ICU. Surprisingly, when we have done this in a subset of patients undergoing pancreatic resections, we found that we are depleting the patients almost 30% compared to what they are actually required. So the naturally artificial intelligence equations that we make seem to deplete the ICU people about the nutritional requirement. So incorporating this indirect calorimetry seems to make a big impact, and the morbidity of the surgical procedures or the ICU patients could be dramatically reduced once you incorporate this indirect calorimetry into clinical practice. Telemedicine is another specialty. We all know about it. COVID time has taught a lot about it. This is the exchange of medical information from one location to the other using electronic communication. It has become integral part of healthcare, penetrated the public, private sector clinics, and healthcare delivery organizations are on the threshold of a seismic change in clinical care delivery and recognize the value of this virtual care and telemedicine. AI and telemedicine can work as together as perfect partners in providing better healthcare services in future. All of you have seen the mobile apps that we have, or the smartwatches that we have seem to have doing better job than what the clinicians are doing. Some of these technologies were shown in Star Trek movies. Actually, some of the seniors would have seen these Star Trek movies. Pulse oximeters, these meter equipment, which are shown almost about 3 to 4 decades back, and they've come into clinical practice just about a decade or 2 decades back into clinical practice. We have all these mobile mHealth devices that are there. Actually, I'm sure a lot of people who are there wearing these smartwatches right now. These have made a substantial breakthrough in clinical practice, and most of the patients are connected to their clinicians via these smartwatches as in today. The smartphone-based mHealth model, which is incorporating AI, seems to be the next generation healthcare, and all the clinicians practicing could get connected to their patients through these smartphones to make sure that these are monitored adequately and we deliver care in time. There are a lot of helps of this telemedicine, remote diagnosis, monitoring, reducing patient visits, considerable amount of time and labor is saved, and it eases the diagnosis by using this artificial intelligence. And these algorithms, as Dr. Shankar has told you, can analyze the past medical records and provide treatment options and solutions. And it significantly reduces the time spent by the doctors going through the medical records and to prescribe or recommend best suited treatment options. Now, it is also shown that actually our hospital started introducing this, and it reduces the number of hospital visits, helps reducing waiting times during hospital visits, and it updates the staff members 24/7 about the patient influx, the priority of which patients to be seen before, needs for additional beds and other information. And ambulance services are now being integrated by AI, and this artificial intelligence seems to automatically allocate beds in the ICU, as I'll show you subsequently how it is done in our own hospital. Now, these smart robots have come actually in the next, any of the physicians are attending the endoscopy live conference next month. For the first ever time, we'll be showcasing the AIG bot, the smart bot which AIG has created, which is helping in providing healthcare at the residence, especially for elderly citizens. It is able to perform tasks, help people which require support. It understands the environmental condition, behavioral and movement patterns of the patient and automatically adjusts itself. And it is acting as a caretaker to the patient in places where they don't have adequate support. For the first ever time, we'll be showcasing this AIG bot or the smart robot for the first ever time in the AIG Endoscopy Live. I invite all of you to attend this conference. I think Dr. Sangram will be there. I think I invite all of you to come and experience this artificial intelligence during this endoscopy meeting. So gastrosciences is natural intelligence plus some amount of empathy. Now people keep saying that, do you have empathy in artificial intelligence? But artificial intelligence has gone to such an extent that it has started incorporating empathy into this. So as in today, these simulators or mannequins or the artificially intelligent mannequins emote. The emotions are shown as absolutely as similar to the human emotions as in today. You can see these images, and these are getting into clinical practice as in today. Now, the other biggest thing that is going to help is actually it is help to decrease the burnout of the clinicians. Now, the clinician burnout is a concern in the health industry. It is becoming an epidemic as of today. The long working hours, days with increasing stress, frustration, it is leading to emotional exhaustion, depersonalization, and diminished sense of accomplishment. And AI seems to be helping in to decrease the amount of time that we have to spend, decrease how this can be minimized as minimally as possible. And it's a powerful revolutionary tool. Actually, this is another thing that we have incorporated into clinical practice at AIG Hospital. It's improving the diagnostics and reducing the physical burnout of the physicians to a significant extent. And it's also helping in streamlining the administrative tasks. Now, this, as I told you, it decreases the physician's digital screen time, identifies signals that can indicate the symptoms of burnout, and even it tells us, even before you burn out, it will tell us what remedies you have to take care to make sure that you don't end up with this burnout syndrome. Now, as in today, we can keep talking about artificial intelligence, that it can take care of any sort of eventuality that happens. But surprisingly, when you have a thing like this, when you have a casualty or a death, and you have umpteen number of these patient relatives coming and thronging onto you, no amount of artificial intelligence will help. We feel that only natural intelligence could help in these situations, because empathy is what is required at that time. This is what was the concept so far. But for the first ever time, they have shown that artificial intelligence can overcome this also. Now, this is a beautiful study that shows that artificial intelligent robo can counsel the patient's attendants better than natural intelligence. Simple example I'll have to tell you, if you're using a Google map when you're driving, umpteen number of times you take a devious turn or a devious route, the Google does not change the tone. 100 times you change the directions, the tone at which it answers is the same. Unlike what happens in clinical practice, when you have 10 attendants sitting in front of you, first question we answer better, second question we answer better. But by the time it comes to the 10th question, I think we seem to lose some amount of our temper and start getting agitated with the attendants also. So it has shown that artificial intelligence can overcome this aspect of human intelligence in clinical practice. So as I told you, we are talking about tomorrow's hospital. Now hospitals are more specialized. Now the user friendly, the staff numbers will be reduced. Telemedicine will be everywhere. Robots will be more present, which are visible. Now it improves the non-invasive monitoring. Now it will play a role in ICU. Patients will be mobilized early. And there are a lot of ethical issues which can be answered. But I think these, once you answer, tomorrow's hospitals will be AI hospitals. And we are proud to say that AIG is also already incorporated this. And any of you visit this can experience the artificial intelligence to which extent it has been incorporated to AIG hospitals. Training has also changed right now. Conventional anatomical dissections have replaced right now with artificial intelligent dissections. Actually, majority of the medical colleges are using these images as of today. And we have also changed the training program right now. You can see this is an AI-based simulator that we were devised at AIG Hospital along with the Indian Institute of Science, Bangalore. Now, the biggest advantage is as you're doing the endoscopy, it not only shows the images, but it also responds like a normal human being. It gags. It shows actually whatever, if you're not sedated a person and doing endoscopy, whatever the sounds or the gag reflexes that the person will have, it will show all this. And it will also show how we can make a diagnosis of tumors as you're doing this endoscopy. So this is an AI incorporated simulator. So for all the students who are coming into clinical practice, this has got a big role. So it shows various pathologies, how we can choose the various accessories that we have in clinical practice, how it can be absolutely used. And as I told you, as in today it is training, but in future it is likely that we do this on the simulator first and allow the computer do it to advance so that the procedures can be done very safely. And also, the other thing that has happened is actually all of us, we keep thinking that we are the best physicians and the best surgeons across the globe. Surprisingly, unless and until we compare it ourselves with some other surgeon, both within the country and outside the country, we cannot say that we are the best. Artificial intelligence has come to that extent right now. Now we have this Endo Assist that helps us to tell us whether how we can compare yourself with other surgeons or the endoscopists across the globe. So this is very useful as in today. A lot of our surgeons and endoscopists are using this technology in my clinical practice. They're trying to compare themselves with the other surgeons or the other endoscopists across the globe. This helps not only in improving your techniques, but also helps in projecting yourself to the outside world to tell that you're best as compared to what the other people are. And it is also getting into basic sciences phenomenally. Basic sciences is a part and parcel of our AIG practice. We have a research department here. And we have a whole genomic sequencer as in today, which tells us which diseases the person is prone to in future. So this is a sequencer that is available in AIG hospitals. As in today, it can predict what all diseases a person can have in future. It is going to predict, and it is also helpful in doing some prophylactic surgeries. And actually, all of you who are following the media closely can show that this lady, very famous Hollywood star, strong family history of breast cancer. She got her sequencing done. It is shown that she has got an 83% chance of developing breast cancer. She undergoes a bilateral prophylactic mastectomy. Such is the concept of this sequencing. And the other thing that has come into clinical practice is the islet cell transplantation. Some of you would have heard about islet cell transplantation. Autologous, wherein you take the islet cell from the same patient undergoing surgery, we isolate the islets and give it to the same patient. Allogenic, we take it from the cadaver and give it to the diabetic patients. This allogenic transplantation requires some amount of immunosuppression as in today, but AIG was the first in this part of the world to start this islet cell transplantation. We've been working isolated islet cells in our own lab, and then we started treating these patients who are undergoing pancreatic resections so that they don't develop diabetes in future. We also had an idea whether this islet cell transplantation can be done without immunosuppression. Something like a bioartificial heart that is shown in this movie we were talking about a bio-artificial pancreas. So for the first ever time, we had this device called Therasite, which is available. So the government of India has asked us to showcase this in experimental work. So we have done this. This is the device called Therasite. Now we load this Therasite, is the size of a SIM card. We load this Therasite with islet cells and put it subcutaneously. And this allows only nutrients to go through, doesn't allow any immune cells. And so these experimental work have shown that these animals can be euglycemic. Phenomenal work. We're planning to translate this into humans very soon. In the sense, we load these islets from the cadaver and put it subcutaneously so the diabetic patients can be managed without immunosuppression. So the device will be something like this, which will be loaded with these islet cells. And then you make a small tunnel under subcutaneously and then put it, and this can control the diabetes actually. And we have shown that these islet cells can multiply and stay longer. As in today, the work shows they can stay for about 2 years. And whenever they're depleted, you can always change this small device called Therasite. Now, there are several questions that we keep asking. Actually, artificial intelligence seems to be coming in a big way. Can we reverse fibrosis? Can we generate organs like pancreas? And is research safe? And as in today, we have shown that using these machines in the basic science, we have shown, at least in experimental work, that fibrosis can be reversed. This is a work that is shown in mice to show that fibrosis can be reversed. We are just waiting for this to translate into human practice so that patients with chronic pancreatitis and liver cirrhosis, maybe it is possible that we can reverse fibrosis in these patients without having to undergo major surgical procedures or transplantation. Now, can science regenerate organs? Actually, beautiful science fiction movies with a lot of AI, which shows it can be incorporated. And we also have movies which have shown that tissue regeneration is possible. Beautiful movies which show, and we are getting this into clinical practice as in today. It is possible to regenerate all this. Now, for the first ever time, based on this concept of AI and natural intelligence, we have started growing a segment of esophagus in our own labs. So here we have, see, this is what we have done in a rabbit model to show that we have taken out a segment of esophagus and subsequently taken a stent, and then we put this pluripotent stem cells on a membrane and put it in place of the resected segment. And we have shown that this segment of esophagus can be regrown. This is a dramatic thing that could make a big impact, especially in congenital esophageal atresia. We feel that is going to make a big dent so that we can use this segment of artificial esophagus to recreate esophagus. This, as I told you, it involves a lot of AI, which is incorporated into this to make this a reality. The ultimate thing would be something like this movie, which is shown for the first ever time, that the patient is put on the table. It makes a diagnosis on its own, treats the patient is just walks out of the machine without having to undergo any of these procedures. Now, this has a very bright future. Now, it as in today, it is limited to research, but it's, to come into clinical practice, it takes a lot of effort. As in today, it cannot substitute human clinical reasoning, but we also feel that people also feel that natural intelligence is nowhere behind it. Actually, we have a competing technology which is augmenting natural intelligence. Actually, some of you would have seen this movie wherein basically the intelligence depends on the processing speed. For the first ever time, they've inserted an extra hard disk into the human brain to increase the processing speed. This we thought is a ridiculous idea, but for the first ever time, Elon Musk had made this a reality, wherein they started putting in this chips into the thing to make sure that we are able to do some movements in paralyzed patients. And this is going to make a big dent into clinical practice. So we have shown that actually AI in clinical practice, better understood, better managed, decreases morbidity, mortality with improved quality of life in all aspects of medicine and also in research, training, and burnout. But the biggest concerns are, will hospitals, government, and even individual persons purchase these licenses, which could be expensive? Legally, who would take the responsibility of incorrect diagnosis? But we must carefully consider the ethical ramifications before we incorporate this into clinical practice. Patient privacy is of utmost importance, and we have to assure that this data is used very responsibly in clinical practice. Now, the biggest disadvantage is, like, suppose you're sitting in the outpatient. Do you want to tell the patient that you'll take the help of AI and come back and tell the patient that what diagnosis that you're going to make? We cannot completely rely on artificial intelligence. Now, in the ICU, I mean, do we completely depend on AI? No, because at certain times we have to make sure that artificial intelligence has to take its due responsibility to make sure the sickest of the sickest patients can be salvaged. Now, what if the system crashes or the decisions are delayed during the entire process? Or what if your system is corrupted or hacked by the rival systems? These are all the limitations that we have in current day clinical practice of artificial intelligence. It is likely that any of these things can happen. We see our smartphones are hacked, our computers are hacked. Similarly, these artificial intelligence systems can be hacked. Now, if we understand these limitations of these computers as in today, the impact of science fiction and AI seems to be huge in gastrosciences. So as in today, gastrosciences is surgery, endoscopy, radiology, critical care, basic science, and gastro, with a lot of AI incorporated into this. And if you see this, in 2 decades back, we had all these individual heroes. We had surgeons, we had basic scientists, we had radiologists, we had endoscopists, we had critical care species. Each of them had their own signature techniques and technology, but it has shown that each of them had their own limitations and acceptance. And if you follow these movies very carefully, the Marvel has come out with this new movies called as Avengers, which includes all these people together. So a lot of AI and lot of these specialties, all these specialties that I talked about, the surgical specialties that we have, all these specialties are incorporated right now with AI to make sure that these people work in tandem so that the progress can be made faster and the pace at which the medicine has progressed. Initially, we used to think that science was progressing at a snail pace, but with incorporation of artificial intelligence, it is likely the pace at which we have seen last 3 or 4 decades, we have seen medicine becoming stronger and stronger. But I personally feel in the decades to come, it will still progress at a much faster speed so that the entire medical practice would become safer and it can be better used for clinical practice. Thank you so much once again for the patient hearing.
Thank you, sir. That was an absolutely brilliant talk. It covered all aspects of artificial intelligence. I actually had a list of about 14 questions to ask, and you've already answered every one of them. So I'm really at a loss to know what I'm going to ask our panelists, but I'm sure they will come up with new ideas, their own take on the subject of artificial intelligence. One of the other reasons I absolutely loved your talk was you had some of my favorite movies shown as examples, including the Marvel Universe. And of course, the other was 2 of my favorite paintings, the Anatomy Lesson of Dr. Tulk by Rembrandt, and the Luke Fildes painting of the surgeon. So we are going to refer to that when we come into the discussion, I'm sure. And may I invite our 2 panelists, Dr. Kulkarni from Mumbai, renowned physician, and of course, Dr. Savita. Looking forward to hearing your views on the same area.
Sir, before that, can I interrupt for a minute? Dr. R.K.
Yes, sir.
Singhal, our chief guest, was waiting. He was in the airport to travel. Dr. Singhal, sir?
See that here, he's not seen there.
Yeah, I think we lost him in connectivity. No problem. You can go ahead, sir. The moment he joins, we'll have his address.
He was there at the airport. Sir, Dr. G.V. Rao, fantastic presentation. I have been in this field from 2008 and till now I have never seen or heard any better than this. Even including all my American college of physician dialogues. Savita may agree that Eric Topol delivered it last in ACP in April, but this is absolutely phenomenal. And you took us around the memorial line also with all the Hollywood movies. And the correlation is really absolutely brilliant. And as a physicians, we have learned quite a lot. You covered practically every topics from burnt out to how to increase the diagnostic efficacy and the pathological diagnosis at the spot. There are not many questions, maybe from the audience, but I got only one question. Is there any way in which you can transmit the touch of the lesion through endoscope?
The touch of the endoscopist. Yeah, we have actually, as in today, actually, all this actually, I mean, some of you are coming for the endoscopy meeting, actually, we'll be showcasing this technology. This is all available as in today. It is nothing that I'm talking about futuristic. All this is available as in today. But only thing is, it is making, as in today, it will tell us whether it's a neoplastic lesion or a non-neoplastic lesion. But I think the next generation, the endobrain or the lapro brain that you're talking about will tell us whether it's well differentiated, moderately differentiated, or poorly differentiated cancers actually.
Can haptics help you in this?
Yes. Yeah,
The
actually, very good question, sir. Actually, as we're simultaneously developing this entire technology, haptics is coming in a big way. Actually, as in today, the robotic surgery that we have, actually, laparoscopy did not have much of haptics. But when we start doing robotic surgery, we are getting a lot of that feel that you are able to feel on open surgery. Also, we are able to feel on the sensors right now.
Thank you very much. Thank you. Over to Sabita.
Dr. G.V. Rao, you covered it all. I think there are going to be very less questions for all of us here. This was very comprehensive. You pretty much, I mean, we talk about artificial intelligence in a big way in most of our conferences in the high level, I mean, the larger picture, which is not necessary for our physicians to know, physicians or other, but you dwelt into the details of every single little thing there that we could actually see AI in front of, working for our patients, working for our physicians and surgeons in a big way. Thank you very much, Dr. G.V. Rao.
Thank you so much.
Right. I do have some questions, sir. You started out by defining the three different kinds of artificial intelligence, the narrow, the general, and the super intelligence. But I'd like to know a little more for the sake of our audience. What is the difference between machine learning, artificial intelligence? What is the role neural networks have to play? If you could just take us, any of the panelists can take us through these 3 or 4 areas, because this is where we get confused. What is the role of these different machines in the machine learning process, and how do they contribute to artificial intelligence?
I think the panelists are there. I think they want to take this forward.
I just like to add something very simple. See, the Deep Blue computer defeating Garry Kasparov. That was a simple machine learning in only one step, that is playing chess and seeing all the innumerable possibilities which are associated with it. The image recognition and the pattern recognition, which we saw in COVID time, that you do a CT at 10 p.m. and you get a report at 10:02 minutes. That was all image recognition, image pattern image recognition. And then came all the large language models, in which you have got a clinical medical decision system, finding the drug interaction. And now what we are having is a multimodal AI. In multimodal AI, you have got audio, you have got text, you have got video, you have got sensor-aided movement disorders. Dr. Rao had said very beautifully, the next word is going to be word of sensors. The sensors can be mechanical, biochemical, histological, electrical, but they are going to tell you many things about it. And there are so many times that these technologies, they merge with each other. We really don't know where machine learning ends and the pattern recognition starts and where the LLM is there. And it is a very fast growing batch. It is a very fast growing batch. It is an overlapping branch. It is physically difficult to cope up even with one segment of digital technology and artificial intelligence, medical sciences, but it is absolutely fascinating. I think Dr. Ravi also can add, because he is a very fond of having nutrition, changing the genomes and the disease outcome. And over to Dr. Ravi, please. Dr. Ravi, you have to unmute yourself.
So you're muted.
Dr. Ravi, you are muted. No, Dr. Ravi, you are muted.
So what I'll do is I will ask Dr. Ravi Kamepalli's questions. He's already posted 2 questions on the group. One is, what is the role of the microbiome and epigenetic factors? Something that's very close to his heart and also to my heart. I've been passionately involved in discussion about the microbiome in the last couple of years, and I know he's been involved in it for a much longer time. So, Dr. Ravi, once you can unmute, you can ask the questions yourself.
Thank you, Dr. G.V. Rao. I mean, like I've known about your presentations for quite some time, and I'm in Atlanta, and I can tell you one thing: India is far ahead in this thinking than US, and it's hard to do things in US than in India. And our ability to be agile will make India the next step in real healthcare delivery. So coming to my thinking on this one is microbiome and metabolic health. Like say for Angelina Jolie, I always think about her process where what if she just get this mutation, you have it, but what if you can do improvement in the teaching her how to change the nutrition? And also maybe that mutilating surgery could have been avoided. And regarding what enthused me more is also your opinion about ICU nutrition. That is where real calamity is happening. I'm telling you. I mean, like as an infectious disease doctor who treats sepsis, I mean, like those people are all insulin resistant by the time. And I go there, I cannot do much for the nutrition in an ICU setup, but I look at them and most of them have metabolic syndrome. Most of them have insulin resistance. Most of them have simple processes that could be instilled. And then we can test glucose and ketones, and we can really, really do improvement. I mean, I would love to chat with the AIG separately if you have to see how we can do it. It is so easy to implement with innovative leadership. And I can tell you, this whole nutritional approach is needing improvement. And then obviously, as a gastroenterologist, you deal with the microbiome. And I know that with understanding my own understanding, without even not doing any stool testing and all, I change my weight by 50 pounds, and I struggle every day to be that. And what is happening is that we are not empowering the patient, empowering the end user, and we need to help build that to everybody. And even like I'm baffled by amazing presentation that you have done. I mean like how can you movily think like that and put all this together? It's like I'm enamored by the whole process of how you put it together. But what enthuses me is how can I take that and take it to my patient in a village back home in India. By the way, I treat patients in India. I guide my friends in India. I have 3,000 doctors in India who I help with wound care, obesity, metabolic health, and all that. So my plea to you is let's figure out the simple approaches and bring tools, techniques, and processes to the people across the country. And I'll be at your service to help you. If anybody in this team wants to do it, I will be at your service, please, because I'm working hard to make this happen in here and trying to understand and trying to do and having the agility to do that with all the tools, techniques, and processes. It is mind-boggling. India will lead what's going to happen. And I'm sorry, I'm on this soap opera. I don't want to steal anything from here. But please, opportunity is huge. The need is great. And purpose is beyond us. And once we are purpose-driven, all this burnout thinking in healthcare will go away. I have 60 charts to do still, but I'm on this conference trying to understand this, where in US I cannot get this. And that's why I have all these friends all around the world, and I jump onto these things to try to learn from you people. So I can shut my mouth up. I'm sorry.
Thank you, sir. Sir, Dr. Singhal, Dr. Singhal, sir.
Sir, you're muted, Dr. Singhal. Dean ICP, could you please unmute, sir? Yes, sir.
Kindly unmute. Dr. Singhal, are you able to hear? Kindly unmute. We are not able to hear you.
Sir, maybe
Yes, now it is done.
tech team can. Yes.
Yes, sir.
Yeah, now you are able to. Yeah,
Thank you,
please.
Dr. Biradar. Thanks to ICP API Karnataka chapter for organizing this update on artificial intelligence in medicine. Under the patronage of Dr. Maya, Dr. Suresh Sagar, Chairman, Dr. Sangaram Biradar, and our colleagues in the governing body, Dr. Ravi Kirti, Dr. L. Srinivas Murthy, Dr. Kulkarni. It is really my proud privilege to be with you on this auspicious day when you are joining this artificial intelligence. Artificial intelligence is a new thing in the medicine. It is the use of medicine machine learning models to help process medical data and to give medical professionals some important insights and improving health outcomes and patient experiences. The artificially intelligent computer systems are being used extensively in medical sciences. Their common applications include diagnosing patients, end-to-end drug discovery and development, improving communication between physician and the patient, transcribing medical documents such as prescriptions, remote treating patients. There is a lot of hope in the world that artificial intelligence will be able to advance the healthcare sector in a big way by a variety of ways, not just in the diagnosis, but patient prognosis, drug discovery, but also serve as an assistant to the physician to provide better health and more personalized experience for the patients. This hope has been fueled by some successful applications in healthcare. A better description of the role of artificial intelligence in healthcare is the future might be artificial intelligence won't replace doctors as is the myth and which is the fear by my doctors, but those doctors will be replaced who don't use the artificial intelligence. With this word, I wish the conference the very best and wish the organizers big success. Thank you very much.
Thank you, sir. Thank you. Over to Dr. Murali.
Thank you, Dr. Singhal. One of the things that I think all people, not just doctors, but everywhere are concerned about is AI going to take away jobs? So I'd like the take of the panelists, all three panelists on this. Is it going to take away doctors' jobs? Is it going to take away nurses' jobs? And you know, what reassurance can we give them that it's going to enhance their performance rather than take away jobs?
I will answer first.
Yes, please.
AI cannot replace doctors, but it will definitely it will definitely replace the doctors who are not using AI. Those people who are not using, they will be redundant. Their postal address will be in their recycle bin. They can recycle themselves if they want to adopt. But there are at least 4 to 5 human qualities, and you may recall my teacher, Dr. R.D. Lele. He always used to say that eye-to-eye contact, human touch, the tone of your voice, and empathy that cannot be brought by AI or any machines. So that gives its answer. Thank you.
Thank you, sir. Dr. Sabita, would you like to add anything to that?
Well, AI is going to take up some specialties are going to be replaced in a better way. Our training programs have to change. They have to incorporate AI so that, like what Dr. G.V. Rao was showing, how to do the AI augmented surgeries, how to use AI systems to make ourselves efficient. All that is going to change. So radiology, the first line is going to be AI. We are going to be in the second line or third line behind there. So we all have to start using AI tools. The training systems definitely have to change. The medical training has to change. ChatGPT 4 could pass USMLE step 1 to 3. So that's a statement by itself. So if a person who's trained in the USMLE can answer, so the chatbot is going to do that. So the chatbot will be sometimes a little better doctor than the average doctor. So, but with training, what we can do as doctors is that with the generative AI coming in, we can use and train the generative AI to build our own systems. You know, somebody was asking in the panel that how can we, you know, what's the cost and all that. So the cost is high now. A single query in ChatGPT cost the company about 0.6 cents US dollars. So that's like $50, right? I mean, so that's a lot of money. I mean, that's a lot of money. So, I mean, if we have to integrate those large language models into our system, the compute power is going to be just amazing. It's going to be expensive. However, what we can do is use the generative AI, bring those large language models into like what AIG is doing. I'm sure AIG is doing that. They are putting that in their backend, training with their own data, make it AIG special. Dr. G.V. Rao can comment on it. We can train the, like, how we train our staff in a different culture. So similarly, we can train, like the clinic can be trained with our own kind of data, our own kind of, to bring that empathy, to bring that local methodology in which we treat our patients. If we don't do that, there is a significant part of our jobs that's going to be taken away from AI.
And
Absolutely right,
speaking-
Dr. Sabita. Actually, what you said is absolutely right. Actually, the technology, whenever some new technology comes into practice, it is bound to be expensive. But in days to come, I think the technology becomes cheaper. We have seen that actually in all the technologies that have come. Actually, one is technology initially could be expensive, but over the time it becomes cheaper and cheaper. Consciously, subconsciously, whether you like it or not, everybody will get involved into this. You don't have to consciously get involved into this. Subconsciously, if you're addicted to your smartphone, you're addicted to artificial intelligence. Simple example, actually. So whether you like it or not, you're integrating into the thing. If you're using a smartphone, actually you're addicted to it. Actually, cannot say that you're not using artificial intelligence.
One of the things that people have always worried about is when a patient walks into the doctor's clinic, the doctor is more often looking at his computer screen rather than at the patient, and spending more time entering data, rehashing the data, looking at the data rather than talking to the patient. But actually, evidence has shown that with artificial intelligence, you can shorten this process of entry. For example, I'm using dictation software, which is remarkable, very accurate, and honestly saves at least 80% of my time that I used to spend typing into our electronic medical record. So actually, it's allowing me to spend more time with my patient. And I think as language models improve, this will become even more, as the patient is talking, it'll listen and start entering the data for me and just wait for my approval.
Absolutely right, Murli. What you said is right. Actually, initially, when we started this practice, we thought we are losing the patient eye-to-eye contact. So very rightly said, actually, this is what we require. As you're talking, it automatically takes in the thing, actually. It is very, very accurate. So now we are not losing that patient eye-to-eye contact right now.
Of course, yes, Dr. Kulkarni, please go ahead.
Sir, it was very rightly asked a question whether the computer on a doctor's table is a companion or a competitor. It is not a competitor, it is a companion. He is your slave. You have to use it. You have to have your own templates, your own shortcuts, the way in which you can put. And I fully agree with Dr. Murli that even my time duration of writing CT-all, some 15-20 drugs in one go, has been reduced to 2 seconds. That is the beauty of it. I think Sabita also must have had the same experience when we are managing the chronic cases. And it remembers the things. Remember example of Watson. What Watson has made a jadoo in all the medical college faculty may not be in a position to remember all the things, but Watson can recall all the things together and he can give a sort of a precision medicine for everybody. Thank you.
Dr. Sabita, you had something to add too?
No, AI scribes are coming in a long way. So I think they are, AI, there will be an AI scribe that's attached to the computer. So we don't even have to look at the computer. It's going to do everything else. Yeah.
But somebody, Dr. Suresh Babu has asked a very important question. What is the cost involved in integrating AI into the hospital information system?
Now, very rightly said, actually, see, cost actually, as I told you, when we're starting, the technology could be slightly expensive. But if we have your own people who can write the algorithms for you, so we have a separate, now you don't have to depend on purchasing an algorithm. Suppose you have your own IT team, people are involved into the thing, I think it becomes a lot cheaper actually. So at AIG, we started our own department right now. So people are starting writing their own algorithms. So, but I'm sure in the days to come, it's going to become cheaper. So many companies develop algorithms actually. So it is going to be competitive. You can choose whichever one which is best suited for you actually. As in today, it's slightly expensive. I cannot say how many rupees or dollars it involves. It all depends on to what extent you want to incorporate AI into the thing actually. But I'm sure technology will become cheaper and this entire concept, and especially in India, it is bound to become cheaper. With so many people, so many IT industries working on it, it's going to become cheap.
one of the other advantages we have, of course, is we have a lot of data. And AI really depends on acquisition of more and more data, and it learns with this. So I think, as you know, all of you have been saying, India is going to be one of the leaders in this area. We have all the
Not
right.
India. Karnataka is the leader, please. Not India.
Sir,
Karnataka.
AIG appears to be leading.
Karnataka is Bangalore is the hub. Bangalore is the hub which has we made all of us proud of.
So don't forget Cyberabad. I know one organization from Cyberabad. The name is Pushpak AI. So the Pushpak AI is a separate, a simple software which can be attached to a CCTV camera. And it has advanced so fast that even it can recognize the facial expressions of the patient. I think that will be one of the very good news for all the small nursing homes or clinics who are running, and they want to analyze the patient's emotion which are sitting there. If somebody is coming with a hockey stick in his hand, in my consulting room, he has not come to play hockey with me. He has come to break my table and my partition only. So, and recognition of unusual objects like full pants with like weapon or a pistol that can be recognized as an unidentifiable object. And these are the things, because we have got more users and it's a simple law of commerce. If you have got more consumers, the cost automatically comes. So with the help of programs like this, and Dr. Biradar, I will definitely request you to put this program on YouTube, free for all the doctors of API IMA. This is one of the fantastic input I have ever seen, and it will stimulate the people to use more and more technology. That please do that. Thank you.
Sure.
We've received many messages about how good this talk was, comprehensive and excellent talk, says Mamta Patil, and so on. There are multiple messages, sir. But there is one important question. You did touch on it in your talk. It says on the ethical and legal aspect, Dr. Pradeep Jadhav asks, do doctors need to take consent and give disclosure to patient on the use of AI in that individual patient's treatment and management? Can the patient sue the doctor on the use of AI without consent? Two separate questions, actually. So,
good question. Actually, as in today, see, surprisingly, the AI also seems to be getting into judiciary right now. But as in today, there is not a single, because like what we have, actually, every single algorithm that we have, it has to go through the DCGI or the FDA. We cannot just write an algorithm and start using on patients, please. It is very clearly shown that it has to go through the same bench to bedside technology that we have in natural intelligence. Every single algorithm has to be tested before it is taken into clinical practice. As in today, these are the basics that are involved. So there are no litigations that are filed as in today. But even I think the judiciary is also looking into this very closely to see how it has to be overcome. But as in now, we are not telling anybody that we are incorporating anything which is newly entered into market into clinical practice. So I think it is going to take time. Slowly, we have to integrate this into clinical practice. It is not that overnight we can take this. But I think in the future consent forms, we have to definitely say that there is some amount of AI component in the entire treatment scheduling and planning.
Either of our other panelists would like to add to that?
Sir, just one simple question. If you are using a ASCVD calculator to calculate the cardiovascular risk of a patient, are you taking a consent? When you are using Google Map, it is one of the biggest store of data. The moment you are downloading the Google Map, you are giving a positive consent to the user. So like that, within 3 to 4 months, the Indian government is going to come out with some consensus guidelines. Not only for they are going to modify the ESR guidelines and all the LLMs and all the projects which are there in the pipeline. There is a very simple saying that the strength of the chain lies in its weakest link. I will put it in a reverse way. The strength of the chain lies in the strongest component. And the strongest component is the medical professional. We as medical doctors, we should dictate. We have got huge amount of data. Even a smartwatch which we are wearing, that is creating large amount of data. And then there are these code writers and the IT companies and the policy makers and judiciary. We must be in a position to tell them that this is going to be one thing which is a revolution after stethoscope in clinical medicine. Thank you.
Great, thank you. A couple of other questions because we are approaching the end of the time. Dr. Masroor has asked a question I have a little difficulty in understanding. He says, how responsible is a doctor for displaying or demonstrating results by using a borrowed AI tool, tricks, techniques, trades, etc. But basically, I think is, are we responsible for using AI as a doctor?
I think, you want anybody? Yeah, I think so. Simple answer would be how dependent are we on the automatic reporting of ECG? See, it is not that actually we, as in today, we are taking help of it actually in our busy practice just to avoid thing. But at the end of the day, we're still reading an ECG on our own. But grossly, at least it will tell us, it will at least alert the nurse who is at the bedside to alert the physician concerned. So I think it is going to be a step forward slowly, but I think as it gets stronger and stronger, I think my personal feeling is actually we cannot avoid this actually. And the legal issues or the ethical issues will keep coming in, I think, and there'll be a solution to that also as more and more things come in.
Dr. Ravi Kamepalli again asks, how can we democratize and empower the end user in understanding their health? And I think this is specifically, the second part is specifically to Dr. Rao. How is AIG approaching that?
Right, actually, we have taken this from the hospital to the patient care right now. Actually, we have now 2-3 things that we have done. Actually, in the hospital, we have entirely the EMR, AI is totally integrated. Now we have adapted some villages right now. Now, first ever time, we have adapted, about 60-70 villages whom we have screened for every possible disease. Now we are integrating that right now, that entire pool of data for the first ever time. As of today, the government of India, or the government of AP or Telangana does not have the data. So we are able to incorporate all that actually, and AI is helping us to evolve the critical steps which are to be taken forward. It is so much of data, actually, it is humanly impossible to see what is important, what is not important. So actually, AI is telling us the important steps that can be taken as around how to prioritize these things actually, and how this can be taken forward. Suppose actually, I'll just a simple example I'll tell you. We have a huge data from this remote villages that we had. Surprisingly, when we fed this, actually, natural intelligence could not tell us, but surprisingly, that showed us that one of the areas to prioritize is IBD, which we never thought was existing in the rural India. And this AI showed us that actually almost 30% of the population seems to be having IBD in rural India. This we never imagined actually that this is so this actually huge data, which it just puts all the information together and it tells us that AI, IBD is one of the components that you have to look out for rural India also, in addition to the diabetes, infant mortality rate, whatever you talk. So this is sort of a thing which are making a sea change in how you visualize the entire concept of medicine.
Of course, on a very simple note, a lot of labs, diagnostic labs, have started putting in information on interpreting the lab tests and making suggestions on how to improve their health.
Yeah, absolutely.
Not very sure how accurate it is, but it seems reasonably good from what I've been seeing.
Yes.
And of course, the patient still wants the doctor to tell him that those details, but it's still extremely useful. I think a last couple of questions. Dr. Sur says,
Sir, I got a question.
Yes,
G.V. Rao. Yesterday only I saw a presentation when there was an app called as a Calorie Mama. You take a picture of the plate and that gives you even the depth of the plate and gives you what are the contents. And you absolutely rightly said, inflammatory bowel diseases are what we see in clinical practice is the tip of iceberg. There are so many. All type 1 diabetics are gluten sensitive. So is there anything Indian, or if you can, as an institute, as a leading institute, get all the standard plates of Maharashtrian, Telangana and Karnataka diets, and give a rough idea that this is 1200 calories, this is 1800 calories, something like that. It will be great. That will be a very big step. I think Dr. V. Mohan had done something like this. He had prepared a big chart. That chart had size comparison. It was the book was like a Indian plate. There is a can compare the size. But if we have got something like this called as eat, snap, and eat, and other types of
Yes,
apps,
yes.
I think you will be definitely a fantastic addition to the.
So
Thank
you struck the nail absolutely right. We have this app for the Western food as in today. Now we have an app for the Indian foods as in today. So basically now I think people are trying to start doing this. Actually, as you very rightly said, you just click on the images, it will tell us how many calories it will have. Maybe future it will tell us, it will further split like in IHC or the immunohistochemistry studies that we are doing in pathology. It will further split to tell us various components of the thing. But as in today, there's actually every on many of the centers are working. Even our own IBD clinic is working on it. Actually, they have created a Mediterranean diet, and actually they're trying to do this. Maybe next time I can show you this app how it is used in day-to-day practice.
Thank you.
Dr. Ravi, I'm not going to go to you on that because it'll start another long discussion. Maybe we can have it at another sitting, which Dr. Biradar will kindly organize. We're already past 8 o'clock. I'm going to respect time and thank Dr. Biradar, of course, for month after month, week after week, organizing these programs. Sir, we are very grateful to you. You bring us so much knowledge. I'm going to thank, of course, a brilliant talk by Dr. G.V. Rao, our very erudite, learned panelists, Dr. Sabita and Dr. Kulkarni. Hand it back to Dr. Biradar and Dr. Vishwanath Krishnamurthy. Thank you very much for giving me this opportunity also.
Thank you, sir. Thank you for your wonderful moderating. I know the time constraint of Dr. G.V. Rao. We have to leave him as early as possible because he's held up in emergency, lined up so many things. So before we conclude, I request Dr. Vishwanath to propose vote of thanks.
Yeah, good evening, sir. Thank you so much for this wonderful program, and special thanks to our speaker, Dr. G.V. Rao. Sir, it was just an amazing speech. Probably as all have complimented you, it's worth it. And I was always wondering, AI is in your AIG hospital. It makes 2/3 of your hospital's name, and no doubt you are proving it right whenever I see. And always it has been inspiring to us. Thank you so much, Dr. Kulkarni sir and Dr. Ravi. I think thank you for that moderation, along with Dr. Bullimohan and Dr. Sabita madam. It was a wonderful discussion. Always, nice to see at the end. Probably you all said that finally the human touch is important, empathy is important. Probably that is more, inspiring to the younger junior doctors who may be a little skeptical. But as one of you said, unless you adopt it, probably we will not have our names in the envelope. I think that is the right thing. We have to use it, and we have to learn how to use it to the best of patients, especially in ICUs. I think it's a boon, as Dr. Ravi was always telling. Thank you, Dr. Biradar sir, for organizing all such great events under our chairman, Dr. Suresh, and past chairman, Dr. Mulliman. Thank you, one and all. Thank you for all the people who have joined. Thank you.
Thank you, Dr. Shankar. Again, sir, highest regards for you, sir. Thank you so much for your words, actually, which you summed it up. Thank you, Dr. Shankar. Thank you so much.
Yeah. Thank you, sir. Thank you. We sign off from the meeting. Thank you, one and all. Stay safe. Good night.
Thank you.